Very respected faculty, seniors, and my dear colleagues. A very good morning to one and all. Today we will begin with we begin with the discussion with a small clinical scenario. So we have a 24-year-old male patient who is a known case of chronic kidney disease on maintenance hemodialysis twice weekly. Now he actually has presented to the ED with complaints of shortness of breath since last 2 days. This is the primary survey. Debashish. So how will you triage this question? Anything else would you like to do before you shift the patient from screening to the red area? Okay. On what oxygen you'll start with face mark or something else? Okay. We'll get to know. Okay. So, Abhiraj, so what would be the possible DDs in your mind when you get such a patient? Okay. Anything else? Okay, the possible DDs would be, as Abhiraj said, depending upon, based on the clinical scenario, the first thing that comes to our mind would be an acute decompensated heart failure, and it can be any other cause of cause of pulmonary edema, non-cardiogenic causes of pulmonary edema. And if the patient is a known case of bronchial asthma, it can be an exacerbation of bronchial asthma or COPD. It can even be a small LRTI or even a pulmonary embolus. So the topic for today's discussion is acute heart failure. Myself, Dr. Sanit K.R., Junior Resident of Department of Emergency Medicine, and my moderator is Dr. Jamshed sir. Okay. So the objectives for today's discussion will be: first we'll be going through the epidemiology, then we'll be briefly discussing the pathophysiology, then we'll go ahead with the classification of acute heart failure, then we'll see how to diagnose this and the management and the disposition part from the ED. Okay. So in the epidemiology, the sad fact is that the epidemiology of heart failure as such in India is largely unexplored. Forget about acute heart failure, even the heart failure, the epidemiology part is not largely explored. So all we have is just pure hospital-based data or community-based registry. That is all we have. So there is a study by Chaturvedi et al., which is called as the INDUS study, which was published in 2016. It estimates that around 1% of the total population of a country is having heart failure. That accounts around 8 to 10 million patients. And there is another finding from that, there is an alarming burden of heart failure in India, despite our population is much younger when compared to the developed nations. So we go on to define heart failure. Heart failure is the pathophysiological state in which the heart is incapable of pumping a sufficient supply of blood to meet the metabolic requirements of body, or it requires an elevated ventricular filling pressure to accomplish this goal. Okay, even if the heart is able to pump sufficient amount of blood, the second part is more important here. It requires an elevated ventricular filling pressure to accomplish this goal. Okay, and according to the 2022 AHA guidelines, heart failure is a complex clinical syndrome with symptoms and signs that results from any structural or functional impairment of ventricular filling or ejection of blood. Okay, so this is from AHA 2022. In that, heart failure is as such being is staged into stage A, B, C, and D. So in stage A, basically the patient is having only some risk factors for heart failure. It may be hypertension, it may be a coronary artery disease, it may be obesity, it may be any exposure to some cardiotoxic agents. In stage B, the thing is that the patient doesn't have signs or symptoms of heart failure, but there may be some structural heart disease or evidence of increased filling pressure associated with some risk factors. Okay, and it is in stage C and D that our main concern comes for the patient presence to ED. The stage C, the patient will be symptomatic with signs and symptoms of heart failure, whereas in stage D is considered as refractory heart failure, but the patient is not responding to the therapy. Okay, so coming to the topic in proper, the acute heart failure is a clinical syndrome of either new onset or worsening signs and symptoms of heart failure. So it can be either a new onset heart failure or worsening of the pre-existing symptoms of heart failure. So it basically
that registry said that the incidence or the prevalence of acute heart failure is much higher in African American people than the other people like the who are working in the military education. So African American or similarly the Asian or the Southeast Asian region, the heart failure is much more common and it involves the early age group.
So acute heart failure basically covers a wide spectrum of wide spectrum of severity. That is, it can vary from a simple gradual increase in leg swelling associated with shortness of breath on exertion and decreased tolerance to exertion, and which can go abrupt on, which can reach up to an abrupt onset pulmonary edema, which can present as severe respiratory distress. As I told, in acute heart failure can be a de novo heart failure, de novo heart failure or a new onset heart failure, and it can be a decompensation. It is so told that around 20% of the cases that present to the ED are de novo heart failure, whereas 80% are basically decompensation from the prior heart failure state. So in AHA, we explained this is a recent update in that the stage C for the symptomatic heart failure part, they are telling that the trajectory of the stage C heart failure may be initially it can be either in de novo heart failure or a resolution from that there may be resolution of symptoms. It can be progress to stage B where it becomes the persistent heart failure and it can be worsening of heart failure. So our concern that our topic as such will focus on these two things, the de novo heart failure and the worsening heart failure part. Okay, going back to the cardiac physiology, we know that the cardiac output is basically directly proportional to the stroke volume and the heart rate. The stroke volume as such is the amount of blood that is pumped by the ventricle during each cardiac systole. Okay, then so the stroke volume is basically dependent upon mainly three factors. It is the intrinsic contractility of the ventricle, depends upon the preload and also the afterload. Okay, I'm not going in detail regarding the how what happens with the contractility, what are the factors, what things happen. We'll just focus on some factors that can increase and decrease the contractility. Because we know that the catecholamines or cardiac glycosides can increase the contractility. Whereas the things that can decrease the contractility, which are more important in our today's discussion, would be there are some physiological factors like hypoxia, hypercarbia, ischemia, or acidosis can decrease the contractility. Whereas there are certain pharmacological agents, it might be calcium channel blockers, beta blockers, or antiarrhythmic drugs, or even alcohol can decrease the contractility. Now coming to preload. Preload is basically the amount of force stretching the myofibril or before the contraction. So it will be directly proportional to the end diastolic volume of the heart. So Gibran, can you please give me what is called as a Frank-Starling relationship or Frank-Starling law? Okay, exactly. So within physiological limits, the force of ventricular contraction is directly proportional to the end diastolic length of the myofibril. As the end diastolic length increases up to a physiological limit, the force of contraction increases. So we got to know that as the preload increases, as I told, as the preload increases, the force, the stroke volume is increasing. Okay, you can see that irrespective of the contractility, even if in case of a decreased contractility or there is an increased contractility, as the preload increases, the stroke volume is going up. Okay. Then the second point is, as Gibran rightly pointed, after an optimal preload is reached, the further increase in preload doesn't increase the stroke volume, that it becomes a flat line. Okay. So as the venous return increases, the end diastolic volume increases and the force of contractility also increases. As such, it increases the stroke volume. Okay. The other thing about venous return is that it increases the pressure inside the ventricle also. Okay. So the pressure inside the ventricle basically depends upon the volume of the blood reaching the left ventricle or the compliance of the ventricle. Okay, it is not alone dependent upon the volume, but it also depends upon the compliance of the ventricle. So it is we can see that in the case of the if the ventricle, in the case of the normal ventricle, as the volume increases, there is not that steep rise in pressure in inside the left ventricular or left or the right ventricular cavity. Okay, so as you can see that there is a gradual rise in pressure inside the ventricular cavity. But as in the case of an acute MI or in if there is fibrosis in case of a chronic heart failure, we can see that the compliance of the ventricle comes down so that there is a steep rise in pressure. Okay? So what happens is that this rise in ventricular pressure predisposes the patient for developing pulmonary edema, so that as the pressure inside the ventricle increases, it leaves back pressure which produces pulmonary edema. So this steep rise in pressure because of the non-compliance of the ventricles predisposes the patient for developing pulmonary edema. Okay. Then coming to afterload. Afterload is basically the pressure against which the heart must pump to eject the blood. Or it can be also told as it is a tension on the myocardial cells during contraction. And this afterload is determined by mainly two factors, that is the peripheral vascular resistance and the cardiac chamber size. Okay, the peripheral vascular resistance, we know it will be depending upon the viscosity of the blood and the cross-sectional area of circulation. Okay, the cross-sectional area of circulation, we know that the colleagues, sir, can you please give me what are called as resistance vessels in our circulation? Yes, the arterioles are called as the resistance vessels because they can change the caliber or contract and increase or decrease the peripheral vascular resistance according to the demands of the body. Okay, then as the viscosity increases, the peripheral vascular resistance again increases. Okay, so we know that when we have got a failing heart or the contractility of the heart comes down, the ventricles basically dilates in order to increase the end diastolic volume so as to increase the stroke volume, depending upon the based on the Frank-Starling law. The problem with increase in this ventricular cavity is that according to the Laplace law, the wall tension is directly proportional to the radius. So that the larger the ventricular cavity, the larger will be the tension over the myocardial wall, and larger will be the myocardial wall, and larger would be the afterload. Okay, so the heart will have to pump against a greater resistance as this afterload increases. So, coming back, the cardiac output is again stroke volume directly proportional to stroke volume and heart rate. The relationship with heart rate is that the cardiac output is directly proportional to heart rate. That is, it increases with the heart rate up to a heart rate of 150 to 160 beats per minute. But after that, we can see that there is a decline in heart rate. It is basically because of the diastolic time decreases when the heart rate goes up. The other factor is that the perfusion to coronaries or the perfusion to the myocardium takes place during the diastolic time. So as the diastolic interval comes down, the perfusion to coronaries comes down, hence the cardiac output comes down. Okay. So moving on to pathophysiology. The thing is that the physiology of cardiac failure should be considered as a dynamic one. The thing is that it continually adapts to optimize the organ function. Okay, when the cardiac output comes down, it tries to bring up the perfusion by various sympathetic activation of the nerve system activation to the RAS pathway, renin-angiotensin aldosterone system, natriuretic peptides, endothelin, vasopressin, and other regulatory mechanisms. But the thing you got to know is that all these mechanisms that try to compensate for heart failure comes at a cost. It leads to some maladaptive structural and electrical events. So this maladaptive structural and electrical events, it again leads to what the fibrosis and apoptosis of the myocardial cells and leading to fibrosis and increase in extracellular matrix. Okay, and this further impairs the diastolic and the systolic function of the heart. So what happens? The loop again continues. The diastolic or systolic function again deteriorates. The heart again tries to compensate, but it comes at a cost, and this loop continues and continues. And it makes the heart failure worse. Okay. Now coming to the classification of acute heart failure. This is based upon the European Society of Cardiology guidelines, which was published in 2005. It helps us to find the cause of the heart failure and to know the precipitants, whereas it guides us in initiating the initial therapy. Okay, but you got to know that it doesn't mean that when a patient presents with acute heart failure that he should fit into a single category mentioned in this. It may be overlapping. It will be overlapping. Okay, so with that insight, we'll go into the classification. There are 6 phenotypic types of heart failure. It is hypertensive heart failure, pulmonary edema, cardiogenic shock, acute and chronic heart failure, high output cardiac failure, and right heart failure. In hypertensive heart failure, we got to know that there will be signs and symptoms of heart failure, but the left ventricular ejection fraction will be preserved and the BP will be more than 140. The other thing to notice is that the symptom onset will be less than 48 hours or 2 days. So such patients are classified into hypertensive heart failure. The next is pulmonary edema. In pulmonary edema, there will be signs and symptoms of pulmonary edema. That is, the patient will be in respiratory distress. There will be bilateral crepitations and auscultation. The oxygen saturation may come down, and there will be findings on chest radiograph or bedside ultrasound. Okay. The cardiogenic shock is if there is evidence of tissue perfusion with a systolic BP of less than 90 millimeters of mercury. When coming on to the acute and chronic heart failure, the thing is that there will be signs and symptoms of heart failure, but that doesn't come up to the level of hypertensive heart failure or pulmonary edema or cardiogenic shock. And the systolic BP in this acute and chronic heart failure would come in between 90 to 140 millimeters of mercury. Okay, and it is typically associated with symptoms of peripheral edema, and the symptom onset will be gradual. That may be over several days. Now coming to the high output cardiac failure, it typically presents with tachycardia and warm extremities in contrast to others, and there may be pulmonary congestion also. And it is mainly it may be associated with anemia or thyrotoxicosis and all. The right heart failure, that is basically a low output syndrome. There may be back pressure from the right atria, right ventricle to the causing raised JVP, hepatomegaly, and pedal edema, and the patient may be hypertensive also. So this is basically the classification of the European Society of Cardiology, which was published in 2005, which helps us to look at the cause and the precipitating factors, whereas helps us in initiating the therapy. Okay. Now this is from AHA guidelines and 2020 guidelines. In that, the heart failure is it is not acute heart failure as such, but heart failure is classified according to the left ventricular ejection fraction into 4 types mainly. It is not just the ejection fraction. It also depends upon the ventricular in left ventricular filling pressure. So the pressure inside the left ventricular cavity. Okay. So the first one would be heart failure with reduced ejection fraction. In that, the ejection fraction will be less than 40%. Then we have a heart failure with mildly reduced ejection fraction, or heart failure with in that it would be the ejection fraction will come around 41 to 49%, with evidence of increased left ventricular filling pressure as seen by rise in the natriuretic peptide levels or invasive monitoring or through invasive monitoring. The last one would be heart failure with preserved ejection fraction. That is, ejection fraction will be more than 50 percentage, but the left ventricular filling pressure would be increased. In between, there is something called as heart failure with improved ejection fraction. So, if the patient presents with heart failure with moderately reduced or reduced ejection fraction, the patient on giving therapy, the patient can improve. Such patients are classified into heart failure with improved ejection fraction. Okay. Now, for the completion's sake, we have another classification called as a Forrester classification. In that, we classify the heart failure into warm and dry. And there is like presence of pulmonary edema and shock. If the patient is having pulmonary edema, we classify them as wet type, and if there is no pulmonary edema, dry. Whereas the presence of shock or shock, they will be taken as cold and not shock warm. Okay. The thing that you got to know is that the type with warm and dry, that is Forrester class 1, is having the best prognosis, whereas the class with cold and wet, that is Forrester class 4, is having the worst prognosis. Now, moving on to diagnosis. So, as such, there is not a single diagnostic test that can tell us that the patient is in heart failure or is having an acute decompensated heart failure. Okay, so the initial global judgment, that is depending upon the history, the physical examination, whatever edgings we have, the sensitivity is around 61% and the specificity is around 86%. So this guideline, so this is basically from the 2022 AHA guidelines, in which initial assessment will include what we normally do. The clinical history will be there, the physical examination part, the possible edgings we can have. Okay, and it includes a measurement of natriuretic peptide levels. Okay, from there we'll go to get a transthoracic echocardiography, by which we can divide the heart failure into one with reduced ejection fraction, one with mildly reduced, or preserved ejection fraction. Okay, this is the general outline for the diagnosis of acute decompensated heart failure or heart failure. Okay, so and then the history part. So in the history part, basically there are certain factors that predisposes, as we mentioned earlier, which were classified into the group of patients that were classified into stage A of heart failure.